Hello, everybody. I think we're going to get started now. Thank you for coming to this last of the sessions for this conference. And I'm pleased to be able to say that we have two patient partners on our panel today. First of all, I'm Larry Mraz. I am the Patient-Oriented Research Capacity Development Lead for the BC Support Unit, which simply means that my focus is on patient-oriented research and patient engagement in research. And of course, because I talk a lot about research, I'll probably say that a few times, but learning health systems is going to be the focus of today's talk. And that's more than just research. It includes research, but it includes lots of other things. And I think it's really important to note that learning health systems can be big. They can be complex. They can be systems. They can be clinics. But they all have one thing in common. And can we guess what that is? Well, welcome to the patient engagement part of our programming, because learning communities are the kind of the germ or the basis of learning health systems. And today we're going to talk about how we can engage patient partners and patient and community. I also say patient a lot because I'm part of the SPORE strategy for patient-oriented research, but when I talk about patients, I talk about anyone with lived experience that's relative to the situation, and we'll talk about patient and community partnerships as being very important. So at the risk of rambling on too long, I am going to ask our panelists to introduce themselves, and we're going to start with Annie. Annie, would you like to please introduce yourself?
Thank you for inviting me. My name is Annie Richtera, and I'm here as a patient or community member. I'm involved in patient-oriented research since its inception at the local, provincial, and national, and some international arrangements. And I'm committed to demonstrate the transformative value of patient and community engagement through partnerships in all aspects of health research and healthcare. My views are shaped because of my lived experience as a patient, as a family caregiver, as well as a former healthcare practitioner and educator. My current activities include active involvement at the moment up to 10 research and quality improvement projects. I'm also a member of advisory committees and boards and different capacities. At the moment, I'm also a student at the University of Calgary in the Patient and Community Engagement in Research program, where we leading a peer-to-peer research project in regards of ICU survivors, their family caregivers, and we'll try to create change and best practices for supports. Patient and community engagement is really changing the research landscape, but more work needs to be done, in my opinion, how research is being implemented in the praxis. My aim is to help design solutions for providers to create higher quality, safer care for patients, and more sustainable healthcare systems. Patient partners or people with lived experience are intrinsically involved in the co-production of learning health system. They're an integral part to change. So I like to see the learning health system expanding to a local learning health community, which includes input from stakeholders working in schools, hospitals, health departments, and the community as large. If I may share just quick an example of learning health systems where it was very successful. It was the Clinical Trials BC COVID-19 Coordination Initiative. There was a multidisciplinary team, including 3 people with lived experience. And it was a local response to the COVID-19 pandemic. A learning health system to achieve integrated health research and responses and services through collaboration, facilitate cooperation, and avoiding duplications. Really a strong focus on the outcomes and what was important for the people. The other focus was really for rapid integration of evidence, because we didn't have the luxury of time on our side. The patient partners created a paper, Research is Care, Care is Research. And this got widely distributed to the Ministry of Health, all the different health authorities, decision makers, with great responses. It created opportunity to strengthen the learning health system infrastructure into future practice and policy changes. Thank you for having me.
Thanks, Annie. And I think it's really great that you mentioned how important it is to have people with lived experience in this. When we talk about learning communities, these are the people that are needed together to create the right environment and the right team to tackle a real problem in the health system. So anybody that is involved, anybody who has interest in this problem, should be invited to be in this community. And so now we're going to go on to Sue, because Sue wears a couple of hats in her work in being a patient partner and an advocate for patient engagement. Sue?
The unmuting. Thank you so much for having me here today. Annie, you're a hard act to follow, so hopefully I'll do my best. As Larry said, I have two hats here today. So one is my work. I work with Vancouver Coastal Health Authority in Vancouver, and I'm responsible for engaging people with lived experience of mental health and substance use issues in quality improvement, service design, and just general consultation opportunities. That can be a wide range of things, and learning communities are really a burgeoning area of interest for me, as well as I think the work that we're doing with the health authority. On a personal level, I too have been patient and family advisor for a number of projects over the years, both on boards and advisory committees and project working groups and research groups. So I think both of them are complementary activities, complementary experiences, and I feel very privileged to have been able to weave my personal experience in with the work that I do. It's very rewarding. We've been asked to talk about a number of talking points. So the things I'm going to focus on are building and sustaining engagement, systemic barriers, and then personal reflection on work that I've done as a patient advisor. So like Larry, I'm using the word patient, but in my actual work, we use the term person with living experience of mental health and or substance use issues. And yeah, so I probably will use peer instead of patient, but it also can involve loved ones or supporters. So building and sustaining engagement. So the number one thing that I like people to remember is communication. So making sure that you're really interacting and informing the folks that you've brought into your community. So recognizing that lay people or outsiders don't have access to the same information tools, and making sure that they're in the loop at all times, and also taking time to build rapport. So settling people in, giving them enough information about context, um, really thinking about who can be an ally for this person. So a supporter that is someone who is looking out to smooth the way for them. And then it ties in with systemic barriers. So often it's really hard to get buy-in from the right people to ensure that the voice of peers is at the table. And also one of the things that's really frustrating as an engagement leader is opportunities that are rushed or planned with not enough lead time. I think the patient experience is so important to have at the table. Thinking about it as a last-minute add-in is just really frustrating for the patient advisors, but also for the people who are helping make this successful. So on a personal note, I was involved with a project, oh gosh, a while ago now, around a cardiac end of life. So we were working on a framework to transpose best practices with a practical tool that practitioners could use in client and family interactions. So the people organizing the opportunity set clear expectations and a timeline, so I felt very informed. There was enough time to get to know the other people on the team and their roles. So that was really important for me to know the context. I was there as a family member, and then there was a person there with lived experience of cardiac failure. And it was really interesting for us to get an opportunity to compare experiences and add value to the work that we were doing. We also had time to reflect on the experience and help with dissemination. So there were reports as well as the framework document. And yeah, overall, it was a really great experience. I had one point person, so that's what I was talking about, having an ally. So someone who was there to really make sure my experience was fulsome and rewarding and not frustrating. So yeah, it's really nice for me to be able to take personal experience and sort of extrapolate that into my work. So thank you. I have used my full time. So,
Thank you, Sue. And
thank you.
your point there that you're bringing value to the conversation because of the lived experience that you have, or the partners and the patients, the community members that come into the learning community. They bring their lived experience and they help make the right decisions, help the team make the right decisions to solve the problem that they're working on. And of course, when we talk about the patients, there are other members of the learning community that we need to consider, and a researcher is a good place to go next. So let's talk to a researcher about their perspective. Lillian.
Oh, thank you, Larry, and really nice to hear like diverse group of perspective. And I am a researcher, and I coming from a background of nursing, so I bring my clinical lens as a nurse, and I try to see how we could work with multiple groups. So in my research, I work closely with a lot of older adults, like we have Lily Wong here that we've been working together for many, many years. So I think there is a lot of kind of like unique opportunities and challenges to work with different groups. And Christina is here, Dr. Christina, that we work together on trying to figure out how we can co-develop these learning communities that could drive learning health system in Vancouver Coastal Health. So you can see that in order to do this, like we have to think about how do we bring older adult partners, and how do we bring in clinicians, operation leaders, and researchers, and we have a lot of RAs, research assistant that are international students. So I wear multiple hats, like being a teacher to help the student to learn about how to work with the older adults. And I'm also a learner, learning from our older adult partners, like what are some of the accommodations and what are their strengths, and not every single older adults we work with, they have different styles. So we try to learn about like what works for each single of them, and what strength, what they brings to the table. Learning using how we use a strength-based approach. I think these things are really important because people have different preferences, right? So I say opportunities and challenges because it's not always so rosy. Sometimes it's very difficult to get to know like what works for people, and we learn from making mistakes as well. And people need to know that you have a safe environment for people to to learn as well. Yeah. So yeah, I'm going to stop from there, and we'll look forward to conversation. Yeah.
Thanks, Lillian. And now we also have Andreas, who's going to tell us a little bit about his work in community engagement in Indigenous health.
Thank you. Thanks, Larry. So yeah, I just want to start off, of course, by thanking Derek Thompson for that opening today, and for the reminder that we've come a long way, but we still have a lot of work to do. I want to thank Musqueam and Silic nations and peoples for welcoming us to their territory. their ancestral occupied territories. And then, of course, thanking the organizers for this event and for welcoming us all here, and my fellow panelists as well. My name is Andreas. I'm a settler of Greek ancestry. I was born and raised here on Musqueam, Squamish, and Tsleil-Waututh territories in what's now referred to as East Vancouver. I am the program manager and scientist with the Indigenous Health Research Unit at the Vancouver Coastal Health Research Institute. And prior to that work, I did a lot of work in frontline work in supportive housing and shelters, specifically in the downtown east side. So that's kind of the lens that I often bring into my work, is working with purposely marginalized and excluded communities. But today I'll be speaking to a lot of the work that we do with Indigenous communities within the VCH region. So a couple of the mandates of our team is to support Indigenous communities with advancing their health research priorities. And so I take that more community lens, I suppose, in this work, whereas some other folks are more on the patient partner side of things. But another aspect of our work is advancing learning health system approaches within the healthcare system as well, specifically to address Indigenous cultural safety or Indigenous specific racism within the healthcare system. So of course, learning health systems is a major part of our work. And there's a few examples of work that we've done with the Squamish Nation's primary care clinic. That's an ongoing partnership that Christina here is also supporting. We're doing work with the Nuhawk Nation up in Bella Coola to try to bring traditional foods into the hospital there, and so we've established a learning community there. And then we're also doing work internally within the healthcare system, where, for example, we're looking at better ways to collect demographic data as well as measure patient experience at VCH. But sort of what my big takeaway is from all of this is that centering and privileging community voices it enriches and benefits initiatives in two sort of ways that we've seen. So there's the tangible side of it where community or patient partner involvement has been critical to defining the research question or diverting the research question to something that aligns more closely with what community needs, to guiding analytical approaches in our work. As well as to the interpretation of findings and coming up with recommendations, as well as areas of future research, which is a huge part of that learning cycle and bringing it all full circle. But there's also sort of intangible ways that we see it benefiting our work. Firstly, it's really important to building relationships, and perhaps afterwards I can talk a bit about the trust in our institutions among Indigenous communities, considering the colonial history and the legacy of that. We also see it establish accountability. So, now we have patient partners and communities that we can point to and really give us that impetus in our work to move forward with, making important change. But it also helps improve trust in systems that a lot of folks don't currently trust. And so overall, this really helps us precipitate sustainable, holistic, and meaningful change that improves outcomes and experiences, which otherwise I feel like would be missed without the involvement, of course, of patient voice and community voice in a lot of this work. So, yeah, that's my opening, my perspective.
Thank you, Andrea. So, we think of what we've heard about learning health systems in the last couple of days here, and how we know now that learning communities are kind of the ingredient, the basic foundational ingredient that can make learning health systems work, and that we have to bring together the interest holders that are all working together to solve a clinical problem, and that patients are an important part of that. So I think we get that, but it's not exactly easy or obvious sometimes how to engage patients or community members in this work. So I want us to go around now again. We'll go through the same order that we did before. And think about some of the issues or the considerations, some of the factors that you think are really important to consider when engaging patients or community members in this sort of work. And then we're going to be thinking about this with an idea of what sort of strategies we can use to address that. But let's start off with some of these ideas. And Annie, I'll go back to you again here.
Yeah, as was mentioned, without respect and without good communication, you're not going anywhere. And changing the culture, promoting the respect, and really preventing tokenistic engagement is integral to learning health systems and working together. The community members have to be really intrinsically involved in the co-production of the solutions. As Sue mentioned, in terms of the public and also patient and community members have to be on the boards, because the boards are the voice of the community. Healthcare is local. So we have to use local aspects. We have to build local communities. And there's a lot of grassroots organizations which are really drivers for change. But we have to bring them to the table. We need every voice at the table to really drive change and make a lasting impact.
Great, thanks, Annie. I'm going to push the question on now to Sue a bit here, please. What sort of issues or barriers or whatever factors you think are important to consider when engaging members of the public in your work?
I agree with everything that Annie said. I think what I would add is build on the tokenistic aspect. I think it's really important to have people speak from their own experience and not feel like they need to be representing an entire population. I think sometimes we want a face or a voice to an issue that's representative, and that's really hard to do unless someone's coming from an organization or a board or something where there's a collective voice. I think often we have folks who are feeling the need to be that type of representative, and really, it's hard to extrapolate. So I'm just wandering here, but the tokenistic piece I think is really important to try and avoid, and being thoughtful about who you're bringing to the table. So do you have the right voices? Do you need more voices? And making sure that they're supported with knowing about their constraints and knowing why they're at the table. I think it's really important to bring people together with a shared agenda. So, I'll be really frustrated as a patient if I come to the table thinking I'm going to be in charge and everything I say is going to be golden, and you're going to hang on every word and everything's going to be enacted. I think that's a setup for frustration, and yeah, so that's where I'm coming from. Thank you.
Yeah, if I may just add to that, and now, so that's like, as a public member, we bring our lived experience to the table, but our perspective. We cannot speak for everybody, but the point is also then, don't just for the big picture is like, yes, I have patient and public engagement and have one person on the team. So one person cannot do the work necessary. So if any way possible, have at least 2-3 members of the public at your table. Thanks, Sue.
Great, thank you. I think this is really, you got some really good points here. The idea of tokenism is really a big issue in engaging members of the community into this sort of work. If you're bringing them to the table, then make sure that you're listening to them, that they're going to be having meaningful conversations. And then the idea of representation, that's another really important idea as well. So let's hear this now. We've heard from our patient partners. Let's hear it from a researcher's perspective again here. What do you think about these issues that are important to you?
Absolutely, and to tag along with you need to have a few patient partners who work together. I think one of the biggest challenges is about getting to know each other, because I mentioned about everyone have different style, and then they have different strengths that they bring to the table. They could contribute to the research. So, how do you I think that often we make assumptions. We make assumptions that I am the researchers and I know the method the best, and this is how we're going to go about doing things. And I need to be open to listen and also to learn together. Because I think a lot of time when patient partners and family partners, community partners, when they come to work with researchers and clinicians and operation leaders, they want to learn about other people's perspectives, and we work together in driving, like what the learning communities is about, like learning together, right? So, but in order to do the learning together effectively, we need to get to know each other, and that's not easy. So it takes some humility, openness to be able to kind of learn like what people, how do they would like to communicate, and how they can contribute the best. And I work with populations that are with older adults, and some of them have dementia. And that does not mean that they could not contribute, and they all have something that unique and very valuable to bring to the table. But it's really about like learning how we could support people to bring their best to the learning communities that we work with. Yeah.
Relationships, relationships, relationships. I hear that one strongly from you. And I think that's a really important thing to be thinking about. If you're having someone at the table again and you want to interact meaningfully with them, you have to have that trust, that relationship.
Yeah, these relationship needs to take time to build. So being patient and take the time and get to know. Sometimes we do a lot of kind of like small things, like having food together and going for dim sum with Lily Wong together. And these things seems to be like small things, but they're extremely important. Yeah.
Well, that's wonderful. Andreas, I'm sure you must have some insight from the Indigenous health research world that would be helpful here too.
Yeah, and I mean, it's tacking on everything that's been said, and I agree with everything. But there are unique challenges with Indigenous communities, and most of that is actually just getting people to the table. So I mentioned earlier, there's that colonial legacy, of course, of our health systems, which were complicit in sort of the federal colonial project, which included, of course, theft of lands, banning of cultural practices, but also in healthcare we saw it through medical experimentation and things like that. So there is this history of folks maybe not trusting the healthcare system. Again, trust is a big theme here I'm noticing. And so that, in a sense, keeps people away from wanting to engage. There's also just the capacity in communities quite thin. We know that Indigenous communities have been under-resourced since Federation, even before that. And so the capacity often isn't there, and it's about, and I have some solutions in terms of what we've been doing to try to address a lot of these concerns as well, but it really is sort of meeting community where they're at. And then lastly, and I know this has been said, but a lot of folks don't feel like their voice will actually impact change. People have shared their opinions, shared their voices, and things haven't moved, and so there's a lot of that, disbelief or distrust, and that involvement will actually lead to any meaningful change. And so it's again about building those relationships and trying to show that we are working towards making change and making things happen. So.
Oh, great, thank you. It's occurring to me how engaging patients or members of the community is a skill. It's not a method. It's not a research method that you can study. It's a skill that you have to learn. And Annie, you pointed out that you should have a few people on your team. And it's not just so that you get a wider representation of voices, but it's also that they can support each other and help each other in being meaningful members of this. So we've had some ideas about some of the issues. Do we have any thoughts on what we think of as sort of solutions? What sort of strategies have you used that really helped you in some way? And this is open to Annie, but to all of us here too.
I can speak to a project I'm involved. It's called The Report, so repurposing routine blood tests in hospitalized patients. And for knowledge translation and trying to implement these changes, I often get invited with the principal investigators, with other team members, to continued education sessions at the hospitals. And so that we really share our findings, we share the impact, and from my side, from a patient or a family caregiver, how important that is, that for instance, if there is blood tests done, that there's a follow through, that you get explained why first it is done, but then also what happens. Do I get the results? Does it create a change in my care plan. So I think it is really important to implement, or like, it's not the right word, but to have patient and community engagement at the implementation stage.
Well, absolutely. If you're going to implement something, you want to make sure that the people you're hoping to help are actually going to appreciate it and understand it, and that the parameters around that implementation are thoughtfully considering the patient view. Lillian.
I have one very effective strategy, which is food. It's really important that it shows, like spending your time to show respect and having relationship over food or drinks, and that really help building relationship. I remember there's one time that we were very stuck in trying to do some work during the COVID pandemic time, and very hard to get access to work with the clinicians. And we brought bubble tea, and that was a game changer when we were bringing bubble tea, and the staff feel that they're being valued and contributing time with us. And I think really getting to know what the other group what they need, and be respectful about their needs. So clinicians are very busy. If you wanna, like during their work, you want them to come in for an hour to have a focus group with you, you need to be really realistic. But like bringing some bubble tea, like having some short sections with small groups, that works, right? So really think about, the needs and the strength and possibility to work with the group. Yeah, so yeah, using some relational approach, relational skills.
Relationship and skills. Yeah, and you mentioned clinicians, right? And when we think about the way this conversation is going, I'm biased in this. I think about research and researchers and patients and working together. But clinicians should be involved in this work. Healthcare decision makers should be involved in this work. And yesterday I heard Andrew Day say that if the research findings that come to him should show how they're going to help him. It shouldn't just be, oh, these are pretty research findings on a plate. They need to show how they can help. Engaging patients and community members can help us do that, because they can tell us what was really important about this research. Yeah, so, Andreas.
Yeah, no, I see there's a question here. I don't know.
Oh.
It's not a question, comment.
Okay.
So as a low-income disabled patient, money is much more effective than food. And I mean,
Can you repeat that?
as a low-income disabled patient partner, I'm very active. I'm all over the place. I don't get paid for everything, but money is much more effective than food. Just, to me, like $100 is like a tenth of my income, right?
Yeah, actually,
And I mean, I'm not asking to be rich, and I also don't want to be the only one at the table who's not being paid.
Yeah, thank you for that question. That was actually one of my points as well, is really honoring community and patient time and expertise. And that's at the individual level, so through things like honoraria, of course. Food is always something that people appreciate too. But in the context of our Indigenous work or working with Indigenous communities, it's also sort of following local protocols and cultural activities and thinking about how that ties into the research design and the question as well. But in addition to that, I agree, honorary is a huge part of that, and even current rates are quite low. I think people deserve to be paid a bit more as well. But there's also, in the context of Indigenous communities, there's that collective level too, for example. So we talk about things like profit sharing when there's innovations that are being commercialized. We think about co-authorship. But we also think about capacity development, so supporting communities to develop their own capacity so that they don't have to depend on institutions, and that they can look at their research questions on their own if that's how they want to proceed. But also looking at alternative knowledge translation outputs. So, our academic institutions, publications are huge, but in our work, for example, with Squamish Primary Care Clinic, they were really interested in looking at oral history, and storytelling is a big approach within Squamish Nation, and so they want knowledge translation outputs that really focus on that oral aspect. But yes, definitely agree with you, honoraria and reimbursing people for their time is critical.
I'm glad you mentioned reimbursements too. So honoraria, reimbursements, and the food wasn't meant to be a payment. It was meant to sort of create atmosphere and relationship. But absolutely perfect. And I also want to thank you, because I was going to ask earlier, are there any patient partners in the audience here today? And I can't see online, but there might be some as well. So I encourage you, especially the patient partners, to ask questions. You can ask our researchers here on the stage. And also, we have 2 patient partners who are here with us on the panel who are eager to answer any questions. So I don't know if we have any questions yet.
Can I just add as well? It's not just the honorary as well, but it's, you know, bus passes, childcare, it's other aspects to make sure that people can actually engage in the research and get there. You know, taxi vouchers, whatever it might be to. There you go. Yeah.
I just had one thing, not around honoraria and recognition, because I think that's super important. I think when I'm talking to people who are considering engaging or just starting to engage patient partners, I'd rather they start small and be successful and authentic than try and do something on a larger scale without being prepared. I think it's respecting the time and the energy of the patient partners, and also setting everybody up for success. So that's what I want as a takeaway. Thank
Well,
you.
that's great. Perfect. Like any other skill, practice makes perfect, right? So now I think, Tia, you're going to read off some questions for us? Yeah.
Can you turn this one up? Yeah. So the most popular question currently is, how do we address epistemic injustice in learning health systems where vulnerability and experiential knowledge are desired in theory, but only safe or privileged for some?
All right, who wants to take that?
I am happy to, yeah. And the inequity issue is very real. It's very problematic, and we just don't do the work because we work with the people that's easy to work with. So we have to think about being strategic to work with the underrepresented group, right? People that they often have some barriers to come to the table. So we have to find out what we could do to remove those barriers, to help people to feel that they are welcome, they are valued, that to be part of the work. So in my work that I'm looking at, like how do we bring older adults, we're looking at transitions care. How can we support patients with dementia from acute care to long-term care? So it's not possible to do this work without patient partners and families who understand what are the issues and what their experience were like. So, but in order to work with this group, that we really have to work very hard to try to find how we can bring these people to the table and also help the clinicians, operation leaders, and other researchers, that everyone feel that that we need to prioritize this voice, right, and listen to their stories and prioritize their lived experience, knowledge. So knowledge is not just what we find in the academic papers, right? Yeah.
Oh, great, thanks. Anyone else want to speak to that question?
I can.
Yes, you mentioned about having a point of contact. And so for people who are new in their role as patient and public partners, to really know who can I talk to if there is some issues. But before we have to start, really make sure we're taking the time. And we talked about relationships. That takes time. So that it's not it's harder to build relationships on Zoom than in person. So it's great if there is a possibility to meet in person. But then giving this time, really investing this time, having a point of contact, who is responsible, but totally outlining also the rights and responsibility. What is expected from me as a patient partner? What can I expect from the team? And this builds respect. If you're very clear and your voice is heard, if you listened to and not being rushed, and if really listening, that what am I saying, what is my experience, and how can that help in shaping changes?
Yes, just building off that relationship aspect, that's been critical in our work too. And there's actually a really interesting manuscript or article that's out there. The title is something along the lines of "I spent the first year drinking tea," and it really speaks to the time that's needed to build those relationships. For example, our work with Squamish Primary Care Clinic, that's been 5 years in the making, and we're just starting to get things off the ground. So it's a lot of, it was said in the earlier talk, but moving at the pace of relationships, especially. And that can be, attending community events that are open to the public so that you actually get your face out there and get to meet people. It is a skill. I don't feel like it's that trivial. I think people trivialize it, but it really is just about actually getting out into community. And then I'll also add that I feel like some folks think of patient engagement as a tack-on in a lot of this work often, whereas we really need to shift that mindset to centering patients' voices and the voices of people with lived and living experience. And this comes from something that was shared with me by some elders that we work with, that these stories are sacred and we have to honor them. And that takes, of course, being reflexive and coming to the work with humility, but also being accountable to ensure that what's being shared with you is implemented. And for us, some of that is also just thinking about that change implementation process. What does that look like? Who, pulls the levers within the health organization? How can we get them involved? Is there organizational buy-in? And all that, I feel like, is critical to actually being able to mobilize those stories into practice as well.
Yeah, that's great. Thank you. I hope we answered that question. Do we have time for more? Yes.
Yes, so I think this relates a little bit to what you were just saying, but there is a question on whether anyone can comment on the practice of matching people with lived experience to research teams for collaboration when there's no time to build relationships. So maybe a bit controversial, but I'll throw that one out there.
Matching patient partners to researchers when there's no time to build the relationship. That could be problematic, but I'd love to hear it from the patient perspective, if one of you was interested in answering.
Yeah, that's a tricky one. And that's why quite often you see maybe the same faces on multiple engagements and stuff, because you build up experience, you build connections. But I think what comes really into play there is having a strong patient community through, like, the BC support unit, for instance. We have a patient partner network. So, and then not having just one patient partner on the team and adding that on so that I have done my duty, but bringing maybe an experienced patient partner in with somebody new, that the experienced patient partner then can mentor the patient or public member who is new in this field and stuff. So create this space on the side to help them, bring them in and stuff. But overall, it is so important to create the time, the effort, train your patient partner. And what you invest there, you will get multiple times back. And because we're not just bringing the lived experience of our illness or chronic diseases or the caregiving with us. We have a lot of other lived experience, from professional, personal experiences, skills we have as hobbies, and so on. So this awareness that we bring multiple streams of support to the team, and like I said, then if you don't have the time, you at least have to have a mentorship possibility for newer people to bring on. So there, again, it comes in, have multiple patient and public members on the team.
And I like what you said. If this is a skill and we're learning how to do it, sometimes it might not be the right match for your patient partner, but it's an important step to take to start learning how to work with a patient partner. Maybe they might not have exactly the right lived experience. And this is controversial, I know, but my thinking is that taking baby steps and building those skills is a really important thing to do.
I'd like to build on what Annie was saying on this topic, if that's okay. Um, I really take umbrage to the term matching. I think it feels like you're checking off a box. You know, it's like, oh, we need one of those and one of those and maybe one of those. So I think thinking about the package that the person brings to the table, I think is really important. I love the idea of having an experienced person there to help a newer person build skills. But I think, just choosing people based on one characteristic can be really tricky. And yeah, I would advise against it. I would really look at the person's motivation for being involved, their experiences, like really get to know them a little bit. You can interview people, like you don't have to go with the first person that gets selected or old faces, but really thinking about people holistically. So that's just my 2 cents. Thank you.
I just wanted to allow one of the comments in the chat about this question to get raised. And so someone noted, instead of just matching people with lived experience to research teams, we should be matching inexperienced teams, especially those who haven't had the time to build relationships with more experienced collaborators. These could include people with lived experience who, as Anna pointed out so well, can also act as mentors. Research teams should be leveraged as mentors, but lack this incentive currently, and we should work on that. So nice way to round that out.
Great, thank you. Now,
If I could just add a little bit about, you mentioned about like the not having enough time to do this work, right? Trying to like match up people to when you have a grant and you need to submit, try to quickly find someone. So I think that having a community so that you are always, having the people to recruit, like in research called snowball sampling. So the patient partners, they know patient partners, and they know community partners. They know, so then you will have time to get to know each other, and you will have ongoing opportunity to build relationships. So when there's a grant coming in, then you know that what are some of the questions important for that community. So then you can kind of start to have the conversations and writing together. But if you just, a week, then you're going to submit that grant and you write everything and just randomly grab someone and put their name on the grant, that becomes very problematic. Yeah.
No, I love that. You're really talking about the learning community again, right? You're building a community that can exist over time to solve, maybe you strike it to solve a particular health problem that you're identifying right now in a setting. But then those people, once they begin to develop the skill, that learning community can then be adjusted. It can bring on new people. It can take on a new life of its own. And you can engage with people over several projects instead of thinking about it from project to project, perhaps.
And it takes a lot of time to drink the 50 cups of tea, right? That you mentioned about 50 cups. Yeah, it takes time.
Yeah, I mean, from our perspective, I've just seen how that rushed approach actually causes more damage and distrust. So please avoid at all costs. I could understand with more pressing or emergent health concerns like the COVID-19 pandemic, how timelines are a bit tighter. But for us, we've been approached after grants have been received, and that's just seen as tokenistic. And it's often hard to engage at those points because it feels like everything's already been determined, and that you are just that checkbox that's needed to be able to move that work forward. So, yeah.
No, absolutely. We have to remember that we have to train the researchers and the clinicians and the healthcare decision makers to do this as well, right? Mm-hmm. Everyone needs to be trained. Yeah. Any other comments from our patient partners?
Just a quick comment, like creating a patient advisory committee. And then you have a pool of people with input, have regular meetings. And the meetings, there's not just patient on the pack, not just patients. There's the researchers, there's research assistants, and ideally have clinicians as well as health decision makers or healthcare decision makers at the table. But having this committee, and you can draw from, and they can help, and they can be involved in different projects within your organization. That's very helpful.
Great, thank you. We have time for one more question?
So I think we have some solutions shared by the audience, and so maybe we can put that up. There was a prompt for folks to share their ideas and solutions, so if we can just switch from the Q&A to that page, and maybe that can prompt the, we have about 10 minutes left to wrap up.
Great, now, how do I see the solutions page?
Yeah. It's coming up.
Okay.
But maybe I can just help frame it as they're loading it. So the prompt we had for folks was regarding, just a moment, regarding patient and community engagement in learning communities, what works and what helps. So share your solutions, practical strategies, and examples of what has worked well. And so I think with this, what we're seeing here, and Larry, you should now be able to see it there if you want to comment.
I can't read it.
You can't read it that well.
I have my
So maybe I'll just give a quick summary, and then the panel can discuss. Oh, there we go.
I'll read the first one here. We have created a patient partners committee as a support group to the patient partner reps in the research or steering committee. By scheduling the PP committee before the other meetings, the group could provide constructive feedback and prepare the patient partner reps for when they sit on the research or steering committee. So this is, I think, is a really great idea. If you're going to, that pre-onboarding bit. So do you want to comment about that? What do you think about that as an option? You do that, Lillian?
Like preparations, yeah. And yes, of course, like spending time and helping patient partners. The patient partners, they want to be having the opportunity to prepare for the work that they are invited to do as well, right? So spending time, answer their questions, and letting them know that what is the plan and what the meeting's going to be about, and so that they could prepare themselves. They do their own research, and they want to be able to bring something that's useful to the team, right? So it's absolutely like vital, and it's also a sense of respect of their time too. They don't want to come to a meeting then you just sit there. They want to be able to make meaningful contributions, right? Yeah.
Great. Do you want to go to another solution? Should we take a look? What else they had?
Yeah, I think we had this both in the chat and then also in these solutions here of just giving a shout out to the Patient Voices Network and I guess other programs like REACH that are helping with some of those connections. So that's another thing. And then I think just noted and really linking into what has been discussed so far, the ability to pay and recognize patient and community partners easily or create models of involvement or employment without institutional barriers. So I don't know if this is a solution, but maybe targeting a problem of just some of the complexities of paying patients that exist in some of our organizations and institutions, and dismantling them being maybe a gateway to broader engagement in learning communities. So I don't know if there's any comments on experiences with some of those barriers, but yeah.
No, that's great. And I also noticed there's someone else that said that one of their best engagements they had was when they were able to meet separately as a patient partner, which speaks to that first one, about providing the actual needed support. And I think you understand what sort of supports to offer your patient partners or community partners by talking to them and asking them and making sure that you're addressing what their needs are, because they're not part of the system in the same way we are, whether a researcher or supporting research or clinicians or healthcare decision makers. We're all connected to the system in a very different way. So we have to recognize that as being
Yeah,
important.
it's really important to see it from, the lens of the other person, right? Because I'm thinking about like when we have like students go out to engage patient partners or older adult partners. Students often, come from their own lens. Like, okay, I email you, book you to come into the meeting, and expect them to show up to the meeting. But our older adult partners don't read emails like what we do. They don't have homework. They don't have papers to submit, right? So they have different style. They might be better to like pick up the phone to talk to them and try to understand, do they need any support with the technology? Like, how about coming on the team calls, right? Like some of the things that people may need a little bit of help so that they get comfortable and using and having tech support. And yeah, all these little things, they really matter, yeah.
Yeah, and that was even the very first question that we addressed on Slido was talking about access and reaching people who are not necessarily connected in the same way that some of the other patient partners can be. So it really is going out there and figuring out how you can reach people and how you can bring them on board and how you can work with them.
Sue's go.
Sue?
No, go ahead.
I was just going to say, I like the idea of I mean, every advisory is going to be different, or how that looks like is often project or, initiative specific, but I think creating that safe space for patients to meet, to have that space to speak within, that peer group, without that external pressure that, came up in that question about injustice and inequities and in sort of decision making, I think is really important. Yeah, it creates that space where people can share in a safe way. Where they're not going to feel attacked or belittled, or and then that could be shared up to the broader group. And I like what was suggested in terms of hosting that meeting before the broader group meets, so that feeds into the direction for that meeting with the researchers and the clinicians and representatives of that patient partner group as well. So, but sorry, Sue, you had some thoughts.
No. I agree with everything that's been said. I think remembering multiple pathways. So, making sure that you're offering up different ways for people to get that information or debrief. So, and planning for engagement. So I can't underscore that enough. If you're running a meeting where you're engaging folks, you need to have a pre-planning meeting. You need to have a debrief meeting. As an organizer, you really need to be putting in a lot of outside energy to make the actual thing a success.
Absolutely.
Yeah.
And now we
The
were running.
planning for it, what comes in there is like put patient and community engagement in your budget.
Yeah,
It has to be in there. It has to be seen that you are consciously preparing for that and not afterwards.
absolutely.
Trying to scramble. And the other thing is this really like the safe space in terms of that people can ask questions. And their strengths is we all have different strengths and or different needs to learn and stuff. So creating this safe space, give the time for the public members to ask questions, but also allow them to challenge you. And don't be too set in your ways. And so it's sometimes good out of a challenge, like you look from a different perspective, and it may lead to some really interesting solutions.
Wonderful. And now we're running out of time. So I would like to sort of finish off by just asking you all to say one word about patient engagement that you would like to give out to the world. Lillian, one word. I didn't tell them I was going to do this, so they're on the spot.
I think care.
Care?
Care. It takes
Perfect.
care to do this work.
Care. Andreas?
I'm going to go with voice.
Voice?
Yeah, centering people's voices.
Okay, wonderful. Sue?
Essential.
Essential? Okay, it's essential to do this. And then Annie?
I have to compassion and collaboration.
Oh, very good. Okay, so thank you all for coming today. I wish to thank the organizers for inviting us here. It's been a pleasure to be a part of this group. The panelists really have done such a great job at talking about the work that they're doing. Thank you especially to our patient partner panelists who come here and put themselves out in front of everybody like this, because it really is a personal and an intense thing to do that. So I honor you for doing that. Thank you. Did I forget to thank anybody else? So I think that's it. So thank you for lunch too, because it's here. Sorry you're online, you don't get any, but thank you all very much. And feel free to contact me if any questions about patient engagement at Health Research BC. Thanks.